Okay. So can you please state your name
Yes, it's Gregory Gleckler.
and your profession, NP, PA, MD, or DO?
I'm a PA,
And which facility do you work at, LIJ or North Shore?
North Shore.
And how many years have you been in practice?
It's been about 8 years now.
Okay. And your race,
Caucasian,
ethnicity? The two options are Hispanic Latino or not Hispanic Latino.
non-Hispanic, Latino.
Okay. Your age
Age is 33 now.
and your gender.
Male.
Okay. So the first couple questions are just assessing diabetes care. So how long have you been managing persons with diabetes in the hospital?
Ever since I started, so about 8 years.
Okay. And how comfortable do you feel taking care of persons with diabetes?
I would say quite comfortable.
Okay. And what are some of the challenges in managing persons with diabetes?
So from our end, just some perspective, I'm actually working critical care, so I've always been in an ICU environment.
Mhm.
I would say a lot of the times it's just erring on the side of avoiding hypoglycemia in our patient population and just careful basal dose regimens in our patients, especially since they can have rapid fluctuations in their clinical status.
Okay. So the next couple questions have to do with steroid dosing. So how often do you manage patients on high doses of steroids?
I would say as of recently, not as often.
So I guess now, what would you say daily, weekly, monthly, or less than monthly?
I would probably say weekly to monthly.
Okay. So how comfortable do you feel in prescribing steroids?
I feel comfortable.
Okay. And how comfortable are you in tapering steroids off?
I also feel comfortable with that as well.
Okay. And what does the term physiological dosing of steroids mean to you?
That's a good question. So I actually don't know the answer to that.
Okay. And when and why would you start a patient on high dose on sorry, when and why would you start a patient on stress dose steroids?
So from my patient population, a lot of times we're still using it in refractory septic shock with higher doses of hydrocortisone we've been utilizing. And also potentially if we have any suspicion for adrenal insufficiency in some of our patients, especially in the cardiac world.
Okay. And a follow-up question, how would you taper down stress dose hydrocortisone?
So when utilizing in patients with septic shock, usually what I do is look for resolution of the shock, demonstrated by clinical response and signs of improvement hypoperfusion, but also weaning of the vasopressors to either off or to a minimally low level. Depending on how long the patient's been on the hydrocortisone, which sometimes could be as few as 3 to 4 days. Usually I wouldn't necessarily do a tapering process. If it's extended beyond 5 to 7 days, typically I would taper probably over about 3 to 5 days.
Okay. And just a practical application. If a patient was chronically on prednisone 5 milligrams and required stress dose hydrocortisone, how would you taper them to prednisone 5 milligrams?
And that's based off of what the stress dose I would give, you're saying?
Correct. The stress dose hydrocortisone. Yeah.
Yeah, so typically I'd probably give a stress dose of 100 milligrams of hydrocortisone. Depending on whether they're able to take oral or not, I would either continue with IV hydrocortisone or otherwise transition over to PO prednisone, probably depending on our patient population.
Mhm.
I would probably continue with IV hydrocortisone, probably wean in, um, probably dropping the dose by 25%, I would say, every 24 to 48 hours, and then eventually transition to a PO prednisone regimen, slowly again tapering down by probably 25% until down to the 5 again.
Okay, sounds good. So the next couple questions have to do with steroid use during the COVID-19 pandemic. So, did you manage patients with COVID pneumonia during the first surge of COVID-19?
Yes, I did.
Okay. During that time, do you recall using steroid therapy?
Yes, I do.
And if so, which steroids did you use?
So we commonly use dexamethasone.
Okay. During the second surge, Decadron was added to the algorithm for managing persons with COVID pneumonia and hypoxia. Did you manage any patients like this?
Yes.
Okay. And what percentage of those patients developed hyperglycemia?
I'd probably say on average about 50 to 75% of them.
Okay, so over 50%.
Yes.
Okay. And how comfortable do you feel in the insulin management of persons with diabetes and Decadron use?
So I feel, are we talking about specifically the COVID population or in general?
The COVID population.
Sure. So, particularly from my end, I would feel comfortable. I'm a little biased just because the patients I took care of on Decadron were all in an intensive care unit setting. So very often we would have a very low threshold just for managing these patients on an insulin infusion until they showed some clinical stability and then eventually bridging them over to basal.
Okay, sounds good. And how do you manage stress-induced hyperglycemia?
So again, I think it's kind of a complex question with a fair amount of variables based off of the patient's clinical status, how their PO intake is as well, and particularly what we're doing with the steroids and whether or not we're tapering down or not. So again, and it's hard to say without having a specific scenario, but very often it would just be managing with an insulin infusion in my patient population until we reached a threshold of having stability, tolerating PO intake. And then again, just figuring out ideally what their needs would be based off of how much steroids they'll be on over the next couple of days, and then deciding what the basal regimen would be.
Okay, sounds good. So here are some practical application questions. If you had a 60-year-old, 100-kilogram patient with normal renal function who was insulin naive with well-controlled diabetes starting on Decadron 6 milligrams, what would you prescribe for them?
Huh. To be honest, I do not know the answer to that off the top of my head.
Would it help if we change the patient's age to 80 years?
No, for me, probably not, just because I think that's just a little outside the norm of the typical patient I would manage. So in that circumstance, I would probably consult endocrinology for some assistance.
Okay. And then what would you do if the patient was on dialysis?
On dialysis, what I would say, whatever I actually decided for the patient, I'd probably reduce, obviously in coordination with endocrinology, what their insulin requirements, I presume, would probably be less. So I'd be reducing by a certain percentage. But again, I would probably still consult with endocrinology based off of that, just because that's a little outside the norm of the critically ill patient I typically manage.
Understood. Okay. So the next are about an insulin algorithm that I'm going to ask. So are you familiar with the insulin algorithm for persons with diabetes receiving Decadron during COVID-19 management?
No, I actually am not.
Okay. So then the next is just a follow-up. Have you used the algorithm?
No, I have not.
Can you elaborate why?
So again, I think just based off of the patient population of patients with COVID I managed in the COVID ICU, a lot
Mhm.
of the times it was more intensive management with an insulin infusion until they're again getting closer to stability.
Okay. I am going to show you the algorithm and then get your thoughts on it. So I'm
Sure.
just going to pull it up. Okay. So here is the algorithm. Can you see this?
I do now, yes.
Okay. So I am just going to scroll intermittently. You tell me when you have finished reading this section, and then I'll just move on. Okay.
Sure. Okay. Yep, you can keep scrolling. Okay. Yep, I have a general idea. Okay.
Okay. And did you see this last part?
Yes, I do.
Okay. Okay. So on a scale of 1 to 10, with 1 being the least helpful and 10 being the most helpful, how would you rate this algorithm?
I would give that probably a 9. It seemed
Okay.
very comprehensive.
Okay. What would help to make the algorithm better?
To be honest, after just looking at it briefly, I wouldn't say much. It seemed very well thought out, and it seemed to cover a lot of the common applications that we would see.
Okay. Sounds good. And when managing these patients, now would you call an endocrine consult?
With an algorithm like that, no, I think I'd have less likelihood to actually call for an endocrine consult.
Okay. Sounds good. Those are all the questions that I have. Thank you so much for participating.
Of course.
Dr. Myers, would you like to say anything?
No, Greg, thank you for